Hello, my name is Molly Manley. I'm a hand and upper extremity surgeon at Crystal Clinic, which is in Akron, Ohio. Today we're going to be showing a technique for the Anatomic C Scapholunate reconstruction. The challenge with Scapholunate reconstruction is the gapping and the rotation. Many techniques address the gapping but not the rotation. The beauty of this technique, it's a symmetric construct that can correct both problems through a minimally invasive incision that actually doesn't even extend to the scaphoid ridge, leading to less scarring and also further motion. The patient is a 24-year-old male that fell playing basketball and has a dynamic static widening on X-ray. You can see that he has SL widening as well as rotational deformity on his films. Here I'm starting to make a dorsal midline incision on the wrist. Those previous two incisions were from a dry arthroscopy performed in the beginning. I'm splitting the fourth compartment of the extensor retinaculum. I then find the PIN and excise this as part of the procedure. I use electrocautery to do so. I then do a ligament sparing arthrotomy to get into the wrist joint. After opening the wrist joint, you can immediately see the static widening between the scaphoid and the lunate, since this is a chronic tear. And so my freer is actually going right in that tear. Now this is not a fixed deformity, so this is something that is definitely in need of a repair, both since this is dynamic as well as him being a younger individual. So first, I place a K-wire in the distal pole of the scaphoid to use as a joystick so I can extend the scaphoid and take it out of rotation. And you can see us levering that bone, the scaphoid up. I do a second joystick in the lunate, and this reduces the deformity from his static chronic SL tear. Once that is reduced, you can either hold this with a coker, or you can also place a wire in the scaphoid and the lunate to help hold this reduction. And you do want to check this under fluoroscopy to make sure you have taken the patient out of DC and you're happy with where your alignment between the scaphoid and the lunate is. Once I am happy with that, I plan my construct of the Anatomic C. There are 4 blind sockets that we place, and you want them to be symmetric. So first I'm placing a drill hole on the scaphoid and then correspondingly dorsally on the lunate. And again, these are parallel to each other. Then I hyper flex the wrist. So you can do this several different ways. Certainly you can use a freer to help lever that down. I'm using the drill to help get that further volar aspect of this scaphoid tunnel. And again, these are blind sockets. So with the blind sockets, you don't worry about breaking out of the bone. And again, here's using the drill as well as hyperflexion to try to really get volarly, because you want this construct to span the ligament insertion. So that's why it's kind of the C shape of the entire ligament. So the first anchor I'm placing in the dorsal aspect of the lunate. Now you can do the exact mirror image and start in the dorsal aspect of the scaphoid as well, but you do want to start dorsally. So I'm placing 2 1-3 tapes in this. There's the black and then the white striped. And I will take 2 of these sutures in a crisscross fashion across the scapholunate interval and into the volar most or proximal hole in the scaphoid. And this is all done with the wrist in flexion as well as the scapholunate interval closed down. You don't want to have to make your anchors do the work. It should always already be reduced. So here's taking a freer to help kind of shoehorn that. So you want to go directly in line with your hole in the lunate. Now, if you ever forget the direction your drill is in, just take the drill bit within your hand without actually being on power because you want to make sure you have the right trajectory of the hole that you drilled. So keep that in mind and then place. Now this is the third anchor, and this one's just going parallel to the joint, or perpendicular to the joint. And the last anchor, you take one from the initial anchor and one from that proximal lunate, and you go again in another crisscross fashion across the scapholunate, as well as doing a horizontal portion into that last hole distally. So that has created 4 suture points across the scapholunate. This really cradles the scapholunate. It recreates the dorsal aspect and the proximal aspect as well, which accounts for it helping the rotation in addition to just the gapping. And so this is why it's a more of a dynamic repair as opposed to just putting one stitch across and hoping that it will create and fix the deformity. And you can see here that with the freer trying to go in at the joint, I literally can't get it in at all. Next, I'll take a 2/0 fiber wire and basically go out the way I came in, repairing that dorsal capsule with the ligament-sparing arthrotomy. So we've done this more complex repair, but what you really need to do is then move him faster in therapy. We have confidence in this repair, so we don't have to wait the 6 to 8 weeks that you would typically for a classic SL repair. I have them in a splint for 2 weeks, they come back, they go to therapy and make a thermoplastic WHO. At that time, they actually start motion right away. And it's important to do that so that they don't get scarred in at the wrist, and so they gain the motion that we're trying to get them.